So now we will talk about gynecologic and obstetric ultrasound. And okay, the evolution started with the B mode ultrasound, and which is the ultrasound as we typically think of of it. That is, the image is in motion, and we visualize it in grayscale. Then in the 80s, the Doppler was developed. In the 90s, the three-dimensional ultrasound was developed. A probe acquires the images sequentially and which are then reconstructed three-dimensionally. Then elastography was developed, which is used to study the consistency of tissue. You can determine and even quantify the hardness or softness of a cyst, for instance. Okay. Image production is done. Piezoelectric crystals produce a beam of sound waves which is transmitted to the tissue and then sent back as an echo received by a transducer. The echoes are converted into electric signals which are visualized on your monitor as snapshots or as a real-time movie. Sound waves are high frequency, greater than 20 kHz, and obey the laws of reflection and refraction. Generally speaking, what is white is called echogenic and signifies high acoustic impedance, for example bone, while black represents low acoustic impedance, such as fluid. We have every shade of gray in between, which we can refer to as isoechoic, hypoechoic, or hyperechoic, if you are comparing two structures. The structure that is less echogenic is hypoechoic, while the other is hyperechoic. Diagnostic ultrasound typically involves frequencies of 215 MHz. The lower the frequency in terms of depth, the greater the penetration of the beam, and the lower the definition. The higher the frequency, the higher the definition, and the lower the penetration, in terms of centimeters away from your transducer. So higher frequencies allow you to see more detail with less penetration, and very high frequency at the potential for adverse biological effects. Ultrasound waves travel poorly through gas, air. General rules. Ultrasound is not a substitute for clinical evaluation. Use abdominal, vaginal, and sometimes transthoracic scans in patients with dyspnea from hyperstimulation syndrome coming from the IVF unit. You have to know how to operate the machine, which is quite complex, okay? So we have a transducer or probe, an electronic system, a signal converter, and a visualization system. There are three types of probes. We have the sector scanning probe, very small, produces a fan-like image, and it can fit into narrow spaces. It's mostly used by cardiologists because it can fit between two ribs. It has poor near-field resolution. And then we have the linear transducer, which produces parallel sound waves. Then we have the curved array of crystals. It can be larger in depth compared to the surface. It's the type of transvaginal transducer we tend to use in gynecology. And transvaginal transducers have a higher frequencies because they go closer to the object of interest. If instead you look at the genital system from the abdomen, you need a low frequency because you are aiming to look at deeper structures. So the machine controls, there is a tracking ball, there is a grayscale management called gain, which is like the brightness of the computer screen. Higher gain means that with lower signals you have information on the screen, while lower gains means that to get information on the screen I need a higher signal in the beginning. It is on the top left, okay. Then we have the freeze function, which allows to freeze the image to take measurements, for instance. Artifacts are inherent component of ultrasound, and there are plenty of them. They are what make ultrasound an operator-dependent technique, which we can say about MRI or CT. Ultrasound is not standardized, partly because the way we use ultrasound depends on the patient. Artifacts are false, multiple, or disrupted information generated from the machine or by the interaction between the ultrasound beam with the tissue. In some rare cases, you can have an advantage produced by artifacts. For instance, with a fluid-filled cyst, you have an artifact enhancement of the posterior walls. Generally, however, artifacts work against us. We can have refraction, mirror images, anisotropism, E-range ambiguity, side lobe artifacts, velocity range artifacts, and Doppler aliasing. High impedance structures inhibit ultrasound waves. Biophysics and bioeffects. Ultrasound is safe, however not without risks. The two effects are thermal and mechanical, and you have both a thermal index and a mechanical index to quantify them. If you continuously keep an ultrasound beam on an object, the object will get warmer, which depends on the time, the depth of the object, the volume of the object, and the frequency you are using. If you study a fetus of 6 weeks and you stay with the pulse Doppler on it for 10 minutes, you can cook the baby. The indices should follow the Alara principle, which says to keep the power as low as reasonably possible. The mechanical index produces cavitations, which are microbubbles, although this tends not to occur in fetal ultrasound because there is generally no air within the uterus. In a situation where you risk the formation of microbubbles, you should reduce the mechanical index. The thermal index. So, although ultrasound is not ionizing radiation, is not without risk. There is data to support that repeated routine ultrasound with Doppler in the third trimester is related to a small but significant decrease in birth weight, and males exposed to ultrasound in the uterus were more likely to be left-handed. Ultrasound on very early embryos is unacceptable, particularly when using Doppler, which has a high frequency. So, gynecology, we can use for many things: assessment of adnexal pelvic masses, IUCD and implanon location, treatment of ovarian cysts and ectopic pregnancy, evaluation of pelvic pain, investigation of menorrhagia, diagnosis of polycystic ovaries, tubal patency studies in infertility, evaluation of primary amenorrhea, screening for ovarian cancer, monitoring of follicle number and growth for IVF, and egg recovery for IVF and ICSI. So with transvaginal ultrasound, you go very close to the uterus, so we can use a high frequency. We can also use this transrectally if you have a case of a woman who has not had prior sexual intercourse. We can also investigate transabdominally, in which case you may discover the presence of an anteverted uterus or retroverted uterus, which is seen when the fundus of the uterus is goes towards the rectum. These are two normal variants, but the retroverted uterus is seen more frequently when you have adhesions and peritonitis or endometriosis. Uterus and endometrium. Here we can see the difference when visualizing the uterus with an empty versus full bladder. We are taking advantage of an artifact in which we have an enhancement of the echo on the back of the cystic structure, that is, when the bladder is full. The endometrium of the uterus follows the ovarian cycle, and we can see differences in the thickness of the endometrium depending on where we are in the cycle. right after menstruation. Right after menstruation is very thin, then increases in thickness and becomes echogenic once we reach the luteal phase. As you see here. Ovaries. Ovaries are approximately the size of an almond or fingernail with 3.5 per 2 per 1 centimeter. Again, a full bladder enhances the visualization of the ovary. The ovary itself appears different depending on the stage of the menstrual cycle. In the proliferative phase, there are many small follicles. After each ovulation, you can find some free fluid in the pelvis. Another peculiarity of the female pelvis is that there is continuity between the external and the internal component, because the salpinx is in direct communication with the peritoneal cavity, and the uterus, which is in communication with the vagina, which is in contact with the external environment. This is why there is a higher rate of pelvic peritoneal infections in the female. Uterine fibroids, it's the most common problem in the female genital tract. Black women have a 30% prevalence, and it's estimated that at least 10% of women have at least one small fibroid. We have pedunculated fibroids, in which the stalk may twist and detach the mass. This is a medical emergency requiring surgery. We also have intramural fibroids, subserosal fibroids, intracervical fibroids, and so on. We can see a calcified fibroid here, which can mimic a cancer on imaging, and is characterized by a peripheral ring of echogenic spot within the mass. We can see subserosal fibroids, which can be visualized better with a saline solution, submucosal fibroids, which can be visualized better with a saline solution infusion of the uterine cavity. This procedure, called sonde hysterography, enables the distinction between submucosal and intramural fibroids or polyps. Okay. Adenomyosis. It's a differential diagnosis with 5 fibroids because we also have uterine enlargement, but in this case it's more diffuse and there is no capsule, no delimitation. We have low myometrial echogenicity with small intramural cysts, heterogeneous and poorly circumscribed area, with a symmetrical wall thickening posterior and displacement of the cavity. This is due to the presence of endometrial glands within the myometrium. It produces massive pain during the menstrual cycle because the endometrium bleeds, then increases in volume, thus causing pain. This is simply an endometriosis of the uterine wall. So then we can have malformations like septate uterus, which can be arcuate, partial septum, complete septum, bicornuate, unicornuate, or didelphic. In the arcuate uterus, the fundus is slightly depressed. If this depression becomes deeper, you can have a partial septum, which can be even deeper to form a complete septum. In case of incomplete of partial septum, it's less than 2 centimeters. If it's more than 2 centimeters, it's a complete septum. If the septum involves the fundus, it's called bicornuate. If the salpinx is missing and the uterine cavity is asymmetric, you have a unicornuate uterus. Or if you have a double uterus, it's called didelphic. It's also possible to have a double cervix or a double vagina. Or you can have an unperforated hymen that results in a medical emergency during menarche, called hydrometrocolpos. This causes pain and requires surgical perforation of the hymen. The distinction between these malformations is very important because some require surgery and others do not. For example, the unicorn weight uterus doesn't require surgery, but a septate uterus should be removed because it can cause miscarriages. The Delphic uterus is not really a cause for operation anymore because the surgery is very invasive and can cause irreversible damage. Endometrial polyps. Polyps can be seen quite well as an echogenic area in the uterine cavity and can appear well defined as a cystic round mass. Can take different shapes and may appear as a long echogenic pattern. It may procure a fuzzy image after which you inject water and get a clearer image with a contrast that allows diagnosis. The approach to the patient in response to the polyps is quite varied. If you have a postmenopausal patient who is bleeding due to the polyps, you can opt to operate immediately, whereas in some cases you may instead choose to do watchful waiting. They may mimic or even transform into endometrial cancer. Endometrial cancer staging depends on the way the cancer invades the uterine wall, and we can diagnose this very well with ultrasound. You can see a deeper invasion of the uterine wall marked by the red arrow here. We can see the vascularization using Doppler ultrasound. Polycystic ovarian syndrome, very common situation, and some even consider it a variant of normal up to a certain point. Of course, when it produces symptoms such as hirsutism or oligomenorrhea, it's pathological. To the left, you can see the normal ovary with the dominant follicle alongside other small non-dominant follicles. You can compare it to the polycystic ovary on the left, where there is not one main follicle, none of them dominate, and in fact these women do not ovulate. This hormonal imbalance increase in testosterone is the reason for oligomenorrhea, hirsutism, and acne. We have then ovarian cysts. We can have simple cysts, hemorrhagic cysts, endometriomas, peculiar cyst but simple to diagnose, teratoma, typical cyst also easy to diagnose, and many other types of cysts. There can be simple hemorrhagic endometriomas and teratomas. Simple hemorrhagic endometriomas and teratomas are always benign. They are physiological with a size less than 5 centimeters, and 90% of all ovarian cysts are benign. These cysts can be managed usually by surgery in the case of a teratoma, and in some cases for the endometrioma. The hemorrhagic cyst and simple cyst usually resolve spontaneously. In the case of a very big simple cyst, we can even puncture it transabdominally. For all the other types of cysts, management is based on the oncological risk and staging. We have many different types of staging, but the one used the most is the IOTA staging, International Ovarian Tumor Analysis. According to the number of septa within the system, number of vegetations or thickenings of the wall, the staging increases. The higher the stage, the higher the need for surgery. You can have also adnexal torsion, a surgical emergency. You can see the laparoscopic view of the early adnexal torsion on the top right and a necrotic torsion on the bottom left. This progression is just a matter of time. The longer you wait, the more ischemic the tissue becomes and the more tissue loss you have. It's very rare to see adnexal torsion on an ultrasound in the absence of an ovarian cyst or something else that is manipulating the tissue structure. So on an ultrasound you'll see a cyst, mass, and using the Doppler you'll see what's called a Whirlpool sign, indicating the vessel is twisted around the salpix with ovarian enlargement. If you have a complete torsion, If you have a complete torsion, you may completely lack the presence of color when using the Doppler. The diagnosis is mainly clinical on the basis of pain radiating posteriorly and to the flank. The ultrasound is used to support the diagnosis. So again, on ultrasound, you can't see the twisting very well, but you can see the lack of perfusion as well as a cyst. Endometrioma is very easy to diagnose, um, particularly when it's severe. When it's mild, it can be difficult to see. You see quite an homogeneous cyst. If you open the patient up, you see a chocolate-colored content with cysts that take up much of the peritoneum. Endometriosis is difficult to treat. You can have ovarian cancer, where we can see many different images with ultrasound. A common denominator is the presence of ovarian cysts with highly vascularized tissue and thickening of the wall. Ectopic pregnancy. The definition of ectopic pregnancy is a pregnancy outside of the uterine cavity. This is a massive chapter, and you have a separate lesson. Okay, starting with the laparoscopic image, you can see the uterus. On the trypanos, you see the typical ectopic pregnancy. You see a lot of free fluids in the Douglas patch, no intrauterine chamber, and the mass outside of the uterus. Okay. The images to the right represent typical ectopic pregnancies. On the bottom right image, we have a cesarean scar pregnancy indicated by small arrows. You can see the Douglas pouch, bladder, and the gestational sac, which in this case occurs as a cervical pregnancy in a patient with a cervical scar. In the middle image, to the right, we have a frank cesarean scar pregnancy in which the bladder and uterus is poorly seen, and the gestational sac is outside of the uterus in the vesico-uterine pouch. On the top right, we have a corneal ectopic pregnancy. In this case, we have a pregnancy in the cervix, which is technically part of the uterus, but is considered ectopic because it's outside of the uterine cavity. If a patient has a pregnancy here, the patient can die or may need a hysterectomy. Or you can have a pregnancy within the intramural part of the salpinx. This is a corneal pregnancy. If you have to operate, you should know that this type is a very destructive surgery. You must cut out an angle of the uterus which will bleed a lot to the point where the patient may lose the uterus. Obstetrics, ultrasound. In obstetrics, there are three causes for death and handicap. We have preterm deliveries, 3% of deliveries, fetal abnormalities, 2% of deliveries, and impaired placentation, 5% of the cases. In total, we have a potential problems in 10% on pregnancies, so 90% of pregnancies will be perfect. To sort out this 10% from the 90%, we do obstetric screening. By definition, we divide the affected population from the unaffected. By definition, you will have some overlap and to false positive rate and detection rate. So you will apply a cutoff. Primary uses for ultrasound in pregnancy are dating the gestation. In fact, many women cannot provide date of last menstrual period. Should be more or less 7 days based on crown rump length in first trimester and can be more or less 10 days based on AC, and FL in second trimester. Identification of multiple pregnancy. Twins have a perinatal mortality 2 to 4 times the risk than singletons. Monitoring for discordant growth with a Doppler reduces risk. It's important to diagnose zygosity. Then identification of breach in third trimester. ECV reduces the rate of cesarean section. And we have few randomized controlled trials of routine ultrasound have shown any effect on overall perinatal mortality and morbidity. Then we have screening for aneuploidy. Cost effectiveness is debated, and we have ethical issues. Then Then you have screening for structural malformations. Sensitivity is 50-80% depending on expertise and equipment, and we have false positives, and screening for EUGR in the third trimester. Sensitivity is 90%, false positive, positive predictive value of neonatal morbidity only 25-50%. Applications of ultrasound in obstetrics are: in a normal pregnancy, we have a fetal viability scan at 5-11 weeks. So we have pregnancy location, number of embryos, embryonic viability, dating of pregnancy, myometrium assessment, uterine agnexa, and cervix. Also, myometrium assessments to exclude fibroids, and trophoblast assessment to exclude molar pregnancies. Then you have first trimester screening scan at 11-14 weeks, second trimester screening at 18-21 weeks, fetal well-being and growth assessment at 22-40 weeks, and intrapartum sonography. We can have a pregnancy with fetal abnormalities, so diagnosis and management of fetal anomalies, and pregnancy with maternal complications like hypertension, preeclampsia, diabetes, autoimmune disease, thrombophilia, epilepsy, drugs, irradiation, or assistance of invasive procedures with amniocentesis, chorionic villi sampling, therapeutic procedures. So successful examination of fetal anatomy at 11-13 weeks plus 6 days by transabdominal or transvaginal scan. We have to decide when during the pregnancy we should screen the patient. The benefit of screening later is that you have more development. If you are good at ultrasound, in the first trimester you can see all the abnormalities of the extremities, almost all the abnormalities of the bladder, kidneys, abdominal tract, heart, head, and brain. But you will not be very able to see abnormalities of the earth or spine. Skull, brain, and face. The eyes, the skull. Here we see the face and the palate, symphysis of the chin, zygomatic process. You can see the extremities, the spine, crown rump length. You can measure this, and it's a dimension that is correlated to gestational age up to 13 weeks, enabling us to confirm the date of the pregnancy. You need to confirm the date if the patient has oligomenorrhea, if the patient had a miscarriage and waited fewer than 3 cycles for the next pregnancy, if she got pregnant while breastfeeding, or if she had amenorrhea. In these cases, the patient doesn't have a reliable menstrual history, so you have to date the pregnancy using ultrasound. The patient does have a reliable menstrual history, you still have to verify the date using the ultrasound, and if they don't match up, you trust the ultrasound. Here we can see the stomach, abdomen, and umbilical cord, kidneys and bladder, heart, 4 chambers, the fetal profile. Ultrasound is truly an operator-dependent exam. Between the far left and far right image is a difference of only 10 degrees, but the difference in the image we see is very different, particularly with respect to the zygoma, which is present in one and not the other. The movement you have to do to acquire very different images are very subtle. We have also screening for chromosomal defects. Trisomy 21 is one of the more common chromosomal defects, and it has a massive impact on individual families as well as the national healthcare system. Some chromosomal defects are lethal, but trisomy 21 is different because these people can live for 60 years and they need assistance, rehabilitation, and a massive effort by the national healthcare system. So we screened for trisomy 21, and you can see that with the advent of ultrasound we saw a major increase in the number of prenatal diagnoses. In the early days of ultrasound, screening was based solely on maternal age. The older the mother, the higher the risk of major chromosomal defects. In the early 90s, maternal serum screening was developed with the use of the triple test and quadruple test. The diagnosis is based mostly on early ultrasound. Prevalence is still increasing because maternal age is increasing, and this is the reason why there is a stable incidence of trisomy 21 live births as well as an increase in prenatal diagnosis. Screening must do a clinical history and screen for biomarkers. We need to know how old the mother is as well as do a physical examination. For instance, she had several miscarriages, then we should perform a karyotype because if the mother has a translocation, the risk of fetal chromosomal defects is as high as 50%. Then we apply a specific algorithm to determine that patient's specific risk. Then we study the fetus for the presence of nuchal translucency. Nuchal translucency is a collection of fluid behind the baby's neck, subcutaneous edema, which increases with gestation. The higher the thickness of the neck, the higher the risk for chromosomal defects, Down syndrome, congenital malformations, particularly cardiac and fetal genetic syndromes. This marker has a very high impact on risk assessment, so we integrate these factors into an algorithm, and if we determine the risk is high, we do an invasive test like chorionic villus sampling or amniocentesis for a definitive diagnosis. If the algorithm yields low risk, we don't have to do anything else. The cutoff for performing diagnostic invasive tests depend on the national healthcare system. In Italy, it's performed if the patient is older than 35 years old. Fetal nuchal translucency has a sensitivity of 80%, which means that of those 200 pregnancies, we are able to diagnose 160 cases. If we add serum markers to this picture, the sensitivity of the test increases to 90%. Then, if we further add other markers such as nasal bone, blood flow within the tummy, ductus venous flow, tricuspid flow, aberrant subclavian artery, hepatic artery, etc., we can reach a sensitivity of 95%. The more markers we add on, the more our sensitivity increases and our false positive rate specificity decreases. So screening based only on maternal age is not sufficient. The a priori risk is based on predictive tables that determine risk based on maternal age. Then we multiply this a priori risk by all the likelihood ratios that we obtain using all the other markers. Likelihood ratio is the difference between the prevalence of a positive marker in the healthy population and the prevalence of the marker in the diseased population. For instance, we have an increased risk of trisomy 21, 18, and 13 with higher maternal age. However, this is not the case with chromosomal sex aneuploidy and triploidy. Nuchal translucency increases with crown rump length. In normal pregnancies, fetal nuchal translucency thickness increases with gestation. 75–80% of trisomy 21 fetuses, the nuchal translucency is above the 95th percentile. Some Downs babies even have a normal neck, so the test doesn't have 100% sensitivity. We also want to look at serum chemistry, specifically beta HCG and PAPE-A, because these are independent of fetal nuclear translucency thickness. We can see that the levels of beta HCG are higher in Down's babies, whereas PAPE-A levels are lower. PAPE-A is also associated with um, low fetal growth, poor placentation, and preeclampsia. If we wait a little bit longer, the difference from normal increases. That is why it's better to wait until 12 weeks, when the difference is good for both serum and ultrasound markers. At 11 weeks and 13 weeks it becomes more difficult, 12 weeks is perfect. For 11-14 weeks the fetus will grow from 4.5 centimeters to 8 centimeters, so at this stage of life the difference of even 1 week can be quite dramatic. So you pull all these factors together, maternal age, nuchal translucency, free beta HCG, PAPE, to determine the risk for Down syndrome. The risk of losing the fetus during invasive diagnostic procedures is 1%, so you really must decide if it's worth that risk. This graph demonstrates this phenomenon. You have the estimated risk of trisomy 21 on the x-axis, and the percentage of invasive testing on the y-axis. You can see that most low-risk mothers will say they don't want to have the invasive test, but of course sometimes we have anxious patients who, despite their low risk, want to know for sure. In the low risk group there is still a 5% chance of trisomy 21. On the other hand, if the risk is high, greater than 1 in 100, 90% of patients will ask for the invasive test and 10% of them will just carry on without chorionic villus sampling. So remember, in addition to maternal age and serum biomarkers, we can also use ultrasound to further analyze the risk. The more we look at, the more specific our assessment. We can look at the angle of the face. We can do fetal Doppler to study the fetal circulation. We can look at the tricuspid valve, the ductus venosus, which connects the umbilical vein with the inferior vena cava just below the right atrium, diverting 40% of the oxygenated blood from the placenta to the fetus by passing the hepatic circulation. It is a vein but transports oxygenated blood, and it is a muscular vein that can alter its diameter according to the oxygen tension. Doppler plays an important role in looking at it in the first, second, and even third trimester. The ductus venosus is abnormal in 70% of Down's fetuses and only 3% of the normal population. Blood flow is supposed to go forward in all the phases of the cardiac cycle, but in this case we see a reverse flow in the ductus venosus. We can also see regurgitation in the tricuspid valve. This is due to the cardiac defects, but is usually this can be due to cardiac defects, but usually due to delayed development in Down's babies. Okay. In Down syndrome, we can also have an aberrant subclavian artery that goes backwards and is interposed between the aortic arch and behind the trachea. This has a likelihood ratio of 25, which means if you find this anomaly, it increases the risk of Downs by 25. This morphology is present in 1% of the normal population. Its presence is also associated with DiGeorge syndrome. So, in our risk, we propose the invasive diagnostic tests, amniocentesis or chorionic villus sampling. In low risk, we reassure the patient, and in intermediate risk, we look for additional biomarkers, ultrasound markers, and fetal DNA. Each chromosomal defect has particular features. For instance, even doing a chorionic villus sampling for trisomy 13, we can see that there is a high fetal heart rate, low hormones, high nuchal translucency, and particular malformations. Free fetal DNA. Each test that you apply is a different detection rate for cumulatively adjusting the false positive rate to 5%. And actually, I would say that this graph is not totally correct because the far right bar, purple, indicating free fetal DNA test, actually has a false positive rate of 1 over 1000 or 0.1%. We don't have any non-invasive tests with 1%, 100% sensitivity. So you do have a blood test at 10 weeks. You do a blood test at 10 weeks, you have a 90%, 99% sensitivity with a 0.1 false positivity for trisomy 21. But you still need an ultrasound to detect the presence of malformations. And this test will still not replace the amniocentesis, which looks at the karyotype because the results only come back in 98% of cases. Why? Because in the blood of a 20-week pregnant woman, 90% of the free circulating DNA is from the mother, while 10% is from the fetus or the placenta. However, there are some women in which the free circulating DNA from the fetus is only 3%, making the test unreliable. If the fetal fraction is below 4%, it is unreliable and we have to redraw the patient. As far as I'm concerned, okay, the only reliable labs are in the USA. There are still 1% of cases in which we cannot achieve results, and this is simply not the case with amniocentesis or chorionic villus sampling. It is a test just for Downs. There are other tests coming out now looking at microdeletions. In any case, the positive free fetal DNA testing should always be followed up with ultrasound and is not grounds for termination of pregnancy on its own. Amniocentesis and chorionic villus sampling are different exams, but they give the same results. They provide a diagnostic result for chromosomal defects. You can do a cytogenetic analysis, microarrays, the more common of which is the CGH array, comparative genomic hybridization, which allows you to compare your karyotype with a standard karyotype, looking for losses or addition of genetic information. So you can do a normal karyotype, a molecular karyotype, or you can go deeply with the gene testing for specific tests. For instance, if your patient comes from a community in which cystic fibrosis is particularly prevalent. The risk of miscarriage changes with gestational age. As you can see from this graph, the risk of spontaneous miscarriage at 16 weeks is 1%. The risk at 11 weeks is 3%. If I do a chorionic villus sampling at 11 weeks or an amnio at 16 weeks, she has an additional 1% chance of miscarriage. Chorionic villus sampling can be performed after 11 weeks, the amnio after 16 weeks. At 16 weeks, the woman starts to have a belly and can feel the baby kick, so a miscarriage can have real psychological effects. The risk of procedure-related mortality is 10 times higher at 16 weeks as compared to 12 weeks, although still quite low, around 1 over 10,000. And the risk of infection and bleeding is 20 times higher. Plus, women want to know earlier anyway. If at 12 weeks I see with ultrasound a nuchal translucency of 4 mm, an absent nasal bone, and an aberrant biochemical analysis, I'm not going to wait to do an amnio at 16 weeks. I'm going to do the chorionic villus sampling right away. The chorionic villus sampling has the same 1 over 100 risk of miscarriage as amnio, and the same percentage of false negativity, 1 over 10,000. We do, however, have a higher risk mosaicism, 1 over 100 as opposed to 1 over 1,000 in amnio. Mosaicism is the presence of anomalies in a certain area of pregnancy and not in other areas. For example, you can have a chromosomal defect of the placenta, which is not present in the fetus, placenta-confined mosaicism. You can also have mosaicism in the fetus, in which a part of the tissues of the fetus have an abnormal karyotype and another part has a normal karyotype. There is no such thing as trisomy 21 of the placenta and not of the fetus. When the nuchal translucency is increased, but the fetus is abnormal in terms of the karyotype, there can be other problems like major defects and even fetal death. These are the syndromes that can be associated with haploid fetuses. Normal karyotype but increased nuchal translucency. You don't have to know all of this below, I just want you to know that an increase in nuchal translucency can be due to many different mechanisms, including heart defects, anomalies of the thorax, lymphatic system, skin, or neuromuscular system. It's always difficult to notice heart defects on on ultrasound, even in the second trimester. By looking at the neck instead, you can improve the detection of heart defects because the higher the nuchal translucency, the higher the sensitivity, the higher the risk of heart defects. Then, if you add on the hemodynamic tests, the sensitivity of the test increases. Then, if you don't find heart defects or chromosomal defects, you have to study more deeply and look for infections, which can cause edema or other genetic anomalies. So you must do a microarray. Twins. There are two kinds of twins that you have to consider: zygosity and chorionicity. Zygosity means that the genetics of the two fetuses are identical. Monochorionicity means that they share the same placenta. Dichorionicity means that they are attached to different placentas and have different circulations. Zygosity is important in theoretical terms because if you diagnose one baby as Downs, you know that the other will have it as well. If you diagnose a genetic syndrome in one baby, the other will have it as well. In terms of hemodynamics, however, they tend to be separate. If we have a situation of monochorionicity, we must also have monozygosity always. If there are two placentas, however, so the chorionicity, they are usually dizygotic. However, in 15% of cases, they can be monozygotic, and in this case, they must have the same sex. Important thing in prenatal diagnosis is chorionicity because being attached to the same placenta increases the risk of miscarriage by 5-fold, doubles the risk of perinatal death, increases the risk of fetal growth restriction by 50%, and doubles the risk of preterm delivery compared to the chorionic twins. Of course, this is on top of the already increased risk of all these factors in twins as compared to singletons. So, there is also a 15% risk of twin-twin transfusion syndrome, 15% risk, and in half of these cases, of this 15%, the transfusion is bad enough to determine the death of the baby, unless you intervene with a separation of the placenta with laser. You can diagnose the chorionicity with ultrasound. Remember, monochorionic twins are the high-risk twins. There is a thick septum lambda sign, we can say it's the chorionic. Whereas if we have a thin septum, we can say it's a monochorionic placenta. So lambda sign, thick septum, two placentas, the chorionic. Tau sign, one placenta, thin septum, that is monochorionic. Starved small fetuses. Screening in obstetrics can lead to treatment. Treatment can even be simply making the decision to deliver the baby. It's absolutely critical to determine when to deliver a premature baby. So if you diagnose placental insufficiency, you need to understand that this baby will grow less, and thus you have to monitor it more. You do an umbilical and cervical artery Doppler, a ductus venous Doppler, and this reflects the oxygenation state of the fetus. You may see the buccal artery start to increase its resistance, and at the same time the fetal heart variation reduces, the amniotic fluid reduces, and the fetus directs the blood towards the brain, adrenals, and heart. So there is a vasodilation of the brain, and the pulsating index of the middle cerebral artery decreases. At a certain point, the heart will not be able to compensate anymore, and the ductus venosus increases the pulsatility index, which means the pressure in the venous system is increasing. This is usually the moment we decide to deliver a baby with fetal growth restriction. If you deliver too early, the baby will not be acidotic and hypoxic, but he may have complications due to prematurity. If you wait too long, you may deliver a baby with brain damage due to hypoxia. Ultrasound in labor and delivery can be used also in labor ward. Of course, checking the cervix manually is critically important, but now we can see the progression of the head with ultrasound. We can see if the fetus is facing up or if facing down. This is critically important if you have to use a vacuum extractor because the traction is different depending on the fetal position. Use of US in fetal therapy. Finally, ultrasound can be used for therapeutic purposes such as fetal anesthesia, such as fetal anemia, in which we can do a fetal transfusion. Ultrasound can also be used to guide laser therapy to separate the babies in case of twin-to-twin transfusion syndrome, and as well as increase in case of discordant growth in monozygotic twins. If the circulation is connected and one fetus dies, the twin will also die, so you must separate the placenta with laser. Now some centers are also doing ballooning for diaphragmatic hernia. We can also treat cystic structures in the lungs with shunts. We can also treat cystic structures in the lungs with shunts, or place a suprapubic catheter for obstruction of the urinary system. We no longer do prenatal shunts in the brain for hydrocephalus. Celosynthesis can represent the future. Is the only way we can administer viruses for gene therapy. We puncture the coelomic cavity at 6-10 weeks, at which point the organs are not developed yet, and in this way we can modify the development and present malformations in high-risk situations for chromosomal anomalies.